Hi everyone, I'm Dr. Akhila, consultant fertility specialist with the Hospital of Manjara Health, Hyderabad. Today we are going to talk about what to do if an IVF cycle has failed and what to do if an IVF cycle has failed repeatedly. What we really need to understand is that when an IVF fails, we should not really worry. It may imply that we need to do a few changes and support. Very importantly, the partners, the couple, they should support each other and take the adequate information from your doctor. All this needs to be done. So we all know what IVF is. That is, we extract the eggs, mix it with the sperm, create embryos, and put it inside the uterus. So ideally, the success of any IVF cycle is about maybe say 40 to 50%. So the odds that it may not work out are slightly higher than that we get a positive result. So this information, it is important that your doctor is transparent and gives you all the adequate information that is required, and you have a clear understanding about what is IVF and what are the chances that you can get pregnant, and the chances definitely increase with repeated cycles. Let's understand where an IVF cycle can fail. So the IVF cycle can fail when we give the injections and the eggs don't grow, or we grow the eggs but we don't get enough mature eggs, or we've got mature eggs, we mix it with the sperm, but there is a problem with fertilization. The fertilization has not occurred, or fertilization has occurred, but the embryos don't proceed on to grow till day 3 or day 5. These are some of the steps in which an IVF can fail. If you do have a good day 5 embryo, upon transfer, if it doesn't implant, that's the final stage where IVF can fail. So now what do we do so that we correct these things, and we don't have a failure? So once you understand that it also depends on the age of the patient, the ovarian reserve, and some of the medical conditions that the couple has or the female has. uh, Importantly, the age of the patient, the younger the age, the better is the success, we all know. So if the age is higher, it won't, or if the ovarian reserve is less, it only means that we may have to try multiple cycles before we can reach the goal of a pregnancy. Now, if we've not been able to grow enough number of eggs, that is, the reserve is low, the AMH is low, then we can think of an option of using probably a donor cycle. If we don't get enough number of mature eggs, then we can think of changing the protocol, the injections, the trigger injections, the time at which we do the pickup, using antioxidants, healthy lifestyle, reducing weight. These are some of the things that we can implement in order to make sure that we get enough number of mature eggs. And if having got the mature egg, we don't have good quality sperm, then we can work on the sperm in terms of using antioxidants. We can do a test called as a DFI, that is DNA fragmentation index. If that is high, we have other modalities like going in for microfluidics or performing a TISA. These are some of the things we can incorporate in order to select the best sperm and use that sperm. If the quality is really bad, again we can go for if not only the quality, if it is severe actinoteratoid zoospermia and these kind of conditions are there, we can go in for a donor sperm option. So these are some of the options to make sure that we get a good egg and a good sperm. And if the fertilization fails, we need to understand we have certain injections to make sure, like calcium, we incorporate that into the protocol to make sure that there is no fertilization failure. And having done all this, if we don't get day 5 embryos, we need to redo the cycle and make sure we get blastocysts. And once we get a top quality blastocyst, and if it is If it doesn't implant, then we are looking at the uterus as well. What can go wrong with the uterus? Importantly, a hysteroscopy or a laparoscopy is something we do to make sure that these anatomical defects are corrected. Like a uterus in the endometrial cavity, we can have adhesions, we can have polyps, septums, calcifications. These are all the things that need to be corrected before we go in for a transfer. If we find any of these conditions that are distorting the uterine cavity, like fibroids which are distorting, adenomyomas which are distorting the uterine cavity, it is better to remove all this and then proceed for a transfer. So this is when it comes to the uterus, and also we need to check for the thyroid, the prolactin, the sugar levels. All this has to be controlled before we proceed for a transfer. If not, these also may cause implantation failures, and it may be a reason for repeated failed transfers. The last comes to immunity. The immunity in the sense that when we check for auto antibodies, autoimmune conditions, we can correct these by using certain medicines like steroids or intralipids, IVIGs. There are plenty of tests, an array of tests where we can detect these conditions like APLA, protein C, protein S, fasting homocysteine. Importantly, if a cycle has failed many times, we need to do the karyotype of the couple. The most important factor could be the embryo. If it does, that is when I was telling you, once a day 5 embryo doesn't implant, we need to know if this embryo is genetically normal embryo, whether it is a euploid embryo or not. Euploid embryo would mean that it has the adequate number of genes that we are looking at, that is 23 pairs. So this technique is called as pre-genetic testing of the embryos. Mostly we do for aneuploidies, but if the couple is a known carrier for any monosomies or structural rearrangements, we can try to rule that out in the embryo as well if they are known carriers. So in spite of having a genetically normal euploid embryo, sometimes it can result in a negative pregnancy test. That is because there could be some mutations that we're not sure about, and it has resulted in a negative pregnancy. And having done all this, the other way of testing, and if a euploid embryo has failed, what we can do next is an endometrial receptive array. That is, the uterus is tested for its receptivity, and the ERA test tells us the time at which we've done the transfer, whether it is appropriate or we need to do it a little earlier or before. So these are some of the tests that are recommended. Also, it is very important to understand when we do a hysteroscopy, we need to take biopsies of the uterus for histopathology, for TB-PCR, also to check for endometritis, the CD138. These kind of tests also are recommended, and if they're positive, in that case, we need to treat them for this chronic endometritis. These are all some of the factors that we need to incorporate when we do another cycle. It is important to understand that once the cycle has failed, we have enough information as to what we did in this cycle, how we can individualize and personalize the treatment for a better result in the next cycle. So that information we need to have and incorporate that information in the next cycle, so we don't do the same thing again. So the change can be with the oocyte, the change can be with the sperm, the change can be with the protocol or the medicines that we've used. Last but not the least, we need to understand when we need to change the doctor. So once the test is negative, it is very important we understand that you having said that everything is proper and it still hasn't, there's no problem in the IVF cycle, it still resulted in a negative test, it does not mean something went wrong with you or the doctor. So, once your doctor has given you adequate information, enough time, has maintained transparency, given you the photographs of the embryos, and all this has been taken care of, you really don't need to change the doctor, is what it is. And so realistically, you need to remember that an IVF success rate is usually between 40 and 50%, and not beyond that. So there are conditions, and that once all these are corrected, there is still something called as idiopathic cause, wherein we don't know why the embryo did not implant, even though it was probably a top quality embryo. So these are the patients wherein, like I've already mentioned, we give them steroids, immunoglobulins, IVIGs, and try to treat these kind of patients. This is all about how to deal with repeated IVF failures. Any questions, please? How many IVF attempts should a patient consider before exploring other options? So, how many attempts is nothing really that we know that you cannot go beyond so many attempts, because IVF is a emotional and a financial journey. It all depends on how much you can cater to. Also, the latest technologies that I've already mentioned is, one is testing of the embryo, that is pre-genetic testing. Also, testing of the uterus, that is endometrial receptive array. The other important thing is laser hatching of the embryo. Sometimes if the zona, that is the outer covering of the embryo, that is too thick, we can do an assisted laser hatching, that is to thin out that zona. So there is easy hatching of the embryo. These are the three important latest technologies we have to ensure positive pregnancy test. I've been married since 2 years. It's been 2 years since my miscarriage in DNC, and ever since I haven't been able to get. So I've undergone 2 times. After, what can I do now? So, like I said, after 2 IVFs, it's important that you need to figure out whether a hysterolaparoscopy was done after a DNC. The chances that you may have adhesions in the uterus are a little higher. So, we need to make sure if there are any adhesions. If yes, that needs to be corrected using a hysteroscopy. Also, if the tubes need to be checked, if there's any hydrosalpinx, we can do an HSG or a laparoscopy to figure out that. A karyotype of the couple, very important to do this to in order to identify, is there any genetic issue, are you a carrier of any mutation or any genes that's causing all this. And from the husband point of view, DFI test, that is DNA fragmentation index. These are some of the tests that are mandatory, along with our detailed history, the medical conditions, and after 2 attempts, we need to use the information that these 2 cycles give us, what drugs have been used, how we can change it, and at what step the IVF has failed, so we can make corrections accordingly. Uh, so the treatment, like I mentioned, it is in this form. That is, the 4 things that we can think of changing is the oocytes, the sperm, medicines, or the doctor. Usually, the uterus is fine. We don't really need to go for surrogacy unless there is a thin endometrium or that is intractable to medicines. Otherwise, it is fine. So these are the things that we can think of changing, having done so many IVF cycles. Side effects of multiple failed IVFs are not really, because the injections also that we use are only for about 10 to 12 days when we create the embryos, And apart from that, the medicines are also for short duration. We don't really expect any long-term side effects with IVF treatment. And it does not mean that every cycle, every transfer you go for, you're creating embryos. If you have sufficient number of embryos in your first IVF cycle, we can use these embryos for the next transfers. So we don't expect long-term side effects. Once the IVF has failed, you can consider another IVF depending on what the problem is, why you chose IVF in the first place, depending on your age, the AMH levels, and your other medical conditions. We can look at another IVF cycle, and you can look at the other IVF cycle soon after you get your period, as early as right the next period. So once the tubes are blocked, the chance that you may conceive naturally or through IVF, IUI is very bleak, or rather, it is not possible once the tubes are blocked. So IVF is the only other option once there is a tubal block or bilateral tubal block. So a living a healthy lifestyle, but why my IVF, even though there is nothing wrong with other tests? So the reason, that's the thing, when all the tests are normal, that is all these array of tests that I have just mentioned, if it is all normal, you fall into the category of idiopathic IVF failure. So for these, we try to change the immunity with respect in terms of giving you steroids, immunoglobulins, or intralipids, or certain other treatments. That is, we also do some antibody testing, and we can also, if those antibodies, that is blocking antibodies, if they are negative, then we can go for a new treatment called as LIT, that is leukocyte infiltration treatment. So these are some of the treatments that we have for idiopathic cases. Thank you very much.